Hey folks, Scott Weingart here, and this is the EMCrit podcast. Today on the podcast, charting for legal protection and what comes along with it, which is patient safety. And this episode it started in my mind because my coaching partner and I, Rob Orman, were doing our Out on Time course for the first time. And that course was built on how to chart so that you will leave your shift on time and yet have maximal billing and in regards to what we're doing this episode on, you are protected legally. Now, that really matters in the U.S. where we have a really litigious society. But even if you're in a place that has more reasonable ideas about medical malpractice, you still want to chart for patient safety. And that's really what this episode is about, is protecting yourself, protecting your patient through good charting technique. And I'm joined by friend of the show, brilliant emergency physician, Mike Weinstock. And the reason we're releasing this episode now, we've been waiting, is the 13th anniversary edition of Mike's book. He has this entire Bounce Back series. All of them are fantastic, but maybe the best in the series, the real perfect bloom to pluck is Bounce Back's medical and legal, because what it does is it takes the cases where docs have been sued, unfortunately, and looks at their documentation and where it went awry, from protecting the doc, protecting the patient. So we're going to take a case from that book, we're going to go over it, and we're going to talk through Mike's and my collected wisdom on avoiding getting sued, being protected if you are sued, and keeping your patient safe through charting. So let's dive right in. Mike Weinstock, I can't tell you how happy I am to get you back on the show, especially because today we're talking about an area that I think is underaddressed in emergency medicine, which is documentation, and in this case, not for billing, but to keep your butt from getting brought to court. Mike, how you doing today?
I'm doing good. And I know I'm a geek, but this is something that I'm super interested in.
Absolutely. In fact, you wrote a book about it, which is one of the reasons I wanted to get you on the show, because the second edition of this amazing book is being released as you are hearing this episode. And so if you've been holding off, now is the time. Tell us a little bit about the book, Mike.
This book has uniquely deposition and trial testimony. So it's called Bounce Backs. It's the medical legal. It's the second book of the 4-book series. But with this new release, we have 6 new cases, and we've updated all of the initial cases. And what it does is, in a very similar way to the other Bounce Back books, it takes you from that initial visit to the Bounce Back visit, but then it shows you what eventually can happen if it goes to legal action. So it's like the TV show Law and Order, right? You got the medical, and then you got the legal.
I love it. That's perfect. And some of the cases we're going to discuss today came right from the book. And if people go to the show notes for this episode, they'll actually see the attorneys interviewing plaintiffs, experts, and the various people involved in the case, and the actual documentation, which is why I find this book to be so powerful, is it's not hypothetical. This is actual stuff that got people sued, and what they wrote and what they could have written potentially to have avoided that misery.
Scott, that's really the key, isn't it? Is to use these legal outcomes to make patients safer. And when you think about us seeing a patient at the bedside, during the course of our careers, most physicians, according to one study, 68% of us will be sued during the course of our career. Wouldn't we like to be able to have the documentation that, first of all, somehow reflects our ability to mitigate that lawsuit from even being initiated in the first place? But secondly, if it is initiated, to say, hey, look, this is my argument for why I thought this diagnosis was occurring, and my argument for why I thought these other diagnoses were not occurring. And unfortunately, with the over 100 medical legal cases that I've done as a medical legal expert, the biggest thing that I find missing is the argument in the medical decision-making, as well as poor data gathering in the history. In fact, there's a formal definition for what medical malpractice is. My definition, for the Weinstock definition, is poor data gathering or medical decision-making.
There you go. And my experience has been, and I think yours has been the same, that failure to diagnose is one of the most common reasons, if not the most common reason, to get a malpractice suit brought against you. But I actually take that a step further and divide failure to diagnose into the one I think that is missed, which is failure to consider. And that consideration in writing is what I see lacking in so many ED doctors' notes. And the ones that really kill me, and I'm sure you've had the same experience, Mike, is where I had to read through a 10-page note. They've written War and Peace in their the documentation, and yet the 3 sentences of I considered X but decided not to test because of Y would have obviated the hour it took them to chart and kept them out of court. Is your feelings the same, Mike?
It's exactly that feeling. And I've said this very frequently with these national residency lectures that I do, is that good job for getting accepted in a residency, graduating. But the way that you're really successful is completing a career in emergency medicine. And if you're there for 2 hours at the end of every night shift because of documenting, that's not really a recipe for career longevity. The studies will show we spend 2 hours of time with the computer documenting for every 1 hour you spend with patient care. And as we just alluded to, is that when you go through these legal cases and you see the deposition and the trial, sometimes it really just is a few sentences of the chart that they're looking at. The normal cephalic head probably is not going to save you when you miss an MI. So smart documentation is the way to go, seeing the forest for the trees. And so frequently I see that there's a question that the patient's presentation is asking. Just for example, chest pain, the patient might be concerned about a heart attack, but the presentation is asking to us, of course, as emergency physicians and clinicians, right? Is this ACSPE or dissection or some other imminently life-threatening thing? The last point I want to make is getting back to what you said a second ago, is this thought of failure to diagnose. Usually that car accident victim who's hypotensive, that's going to be a pretty unlikely lawsuit. You admit the patient or send them, you do a bunch of CTs or whatever you do, right? It's the case where you failed to consider this possibility. Just because you got it wrong, that's not malpractice. So I'll repeat my Weinstock definition of malpractice again. It's poor data gathering, poor medical decision-making, but I did not say failure to diagnose a specific problem, because sometimes, even thinking about the PERC rule, there's 1.4% chance it is still a PE. Still, we should have sent that patient home.
Absolutely. Now, I think a perfect example of what we've been talking about is going to be in the case you've actually sent me, Mike. And this is a case of a 41-year-old woman with chest pain. Tell me a little bit about this.
So this physician, and we can look in the show notes and the actual history, and this is the actual documentation that was on the chart. Interestingly, they described the character as being pleuritic, but then did not discuss later in their medical decision-making note why they did not think it was PE. In other words, answer the question that the patient's presentation is asking. In this specific case, it's unbelievable to me that the medical decision-making note, and I will read it to you here.
Read the HPI and the medical decision-making note. Mike, I think that'll be a good context.
Absolutely. Okay. So it's not that long, really. And this is another really important point, that the history of present illness can have the past history in it, can have review systems, but what the HPI has to have is the history of present illness. So patient is a 46-year-old woman with a chief complaint of chest pain for the last 1 day or so. Patient pain is a tightness across the chest and upper arms, which is worsened with deep breaths, radiates to the left arm. So that's really the entire HPI, Scott. Now, I'm going to read you the rest of the stuff that was in this box, which again is important and good stuff to have in that. PMH of high blood pressure and diabetes, no nausea and vomiting, coughing, blood, syncope, feeling of dew, shortness of breath, sweating and palpitations, nursing notes reviewed, social history smoker, family history cardiac disease after the age of 55. Not horrible, right?
I don't know, Mike.
Been there. We've all sort of been there in a busy day.
All right, why don't you tell us about the medical decision-making, then we could talk about this chart in toto.
This is one of the really astounding things to me, and we're going to talk later about some of the ways that I think we can make our MDM and how we can self-check ourselves with this hard stop of the MDM. But here's the actual quote, MDM, chest x-ray and EKGs reviewed, and I'll be a little snarky here, Scott, if that's okay.
Yep.
Good job for reviewing the test that you ordered, right? You ordered the test, good job for reviewing them. Okay. Albuterol aerosol, captopril, 25 milligrams PO. That's the entire MDM note. And you'll be probably even more astounded when we get to the diagnosis. But I guess I'll ask what your thoughts are on that MDM. It really doesn't address that question that the patient's presentation is asking at all.
Yeah, it's very worrisome to me because, and you shouldn't think this way in a fashion that negatively affects how you actually go through your career. But for me, the question I ask at every MDM is, how is this case going to get me M&M'd? Or how is this case going to get me sued? Or how am I going to fail the patient by the consideration that I have given? And this MDM has so many points of failure, so many possible ways to get M&M'd. And that mindset is, I think, what has kept me safe for so many years now. And this one, it doesn't protect, it doesn't keep the patient safe, and it doesn't keep you out of court. Where should we start, Mike, to analyze where this chart went wrong and what could have been done differently?
Let me just read just briefly the very part of this. Chief complaint of chest pain for a day, so we have the duration. It's a tightness, so we have the character. Upper arms worsen with deep breaths, so we have a little bit more of that character. But again, putting that in there says, could this be a PE, right? Radiates to the left arm. So certainly ACS is still in play. Certainly PE is still in play. We really don't have any information as to possible dissection. In other words, the acuity of the onset, radiation of the depth, ripping and tearing, above and below diaphragm, severity of pain, or what I think is the 5+1. Those were the 5. The +1 is a alternative explanation for the patient's symptoms. So really, we have failed in this HPI to gather data on which to even be able to make a decision as far as MDM. And unfortunately, this was, and I will tell you, this ended poorly. This patient was someone's mother who found this patient later the next morning in full arrest and did chest compressions on their own mother because of a failure of this emergency physician, unfortunately.
Yeah. When it gets to your book, we know the outcome is going to be bad, but it's still,
Yes.
it's an absolute shame that this was the level of the evaluation. And the consideration would have possibly cued a different actual ED course. I find once you start getting the mindset of what could I be missing that's serious, it sometimes clicks of, oh, maybe I should actually work them up for this, or at least go back and ask further questions. So it's not just that we want the chart to look good to keep you safe. Doing good charts actually makes you a better doctor, I found. And I think when we get to other diagnoses like headache, we could discuss that even further, because I think it's one that really rewards this kind of consideration of anything that could be missed, because sometimes you forget in the course of your normal heuristic response. How did this play out in court? Give us a brief summary of that, Mike.
So the diagnosis was hypertension and bronchospasm, either further indicating that this physician didn't really consider the fact that they presented with chest pain. And I'll just give you a brief part of the opening statement. They say, "Good morning, everyone. People come to ED because of chest pain. It's not always fatal, and it's not always easy to diagnose." And in the end, this diagnosis was wrong and it was negligent. And they say the failure to even get a basic history was a violation of the standard. So the plaintiff attorney says that in their opening statement, that the failure to get an adequate history was a violation of the standard. And I have to say, Scott, look, approaching my 30th year as an emergency physician, I sort of agree. And I'm going to tell you a little bit of a backstory also about this case, is that this physician, and this is unbelievable, the physician on the stand admitted that they were wrong. They probably had a heart attack during that time, and told a story about the emergency physician's own mother, who was misdiagnosed by a primary care physician as being a nervous housewife who drank too much. And then this physician's mother had died of a heart attack. And then this physician made the same mistake. Scott, that thing that you said is so important to say to yourself before that patient leaves, not with every patient, but maybe several a day with diagnostic uncertainty or potentially life-ending type of chief complaint, is to say, if they bounce back tomorrow, room temperature and horizontal, right? What did I miss? And how am I going to reflect in the documentation that my argument is correct as far as the decision to either send that patient home or to admit that patient?
Yeah, no, absolutely. Mike, let's go over this piece by piece. And I'm curious to hear what you think about this. I don't really care what was missed or not missed in the history. I'm fine with that. If this history was on a chart that a resident handed me, I'd be like, okay, because I would teach them and hopefully have them, understand why I think it's insufficient. But for me, it doesn't matter so much, because so much of the history I actually need to be on that chart for me goes into the medical decision making. Because Working in an academic shop, usually I let them do the history, the physical, the review of systems, et cetera. But then I take the MDM myself. In fact, in some ways, resident MDMs are harmful because once it's locked into the chart, now I have to actually disabuse the notions that would have raised in people's minds. So in general, I'm doing my own MDMs, and that's where all of the critical questions that I should have asked the patient go, because I'll have spoken to the patient and I'll ask them a very focused set of history and physical questions in my mind that need to be answered in order for me to feel safe to send them home with a benign diagnosis. And do you think there's any problem if a lot of the history that's important goes in the MDM and not in the actual frank HBI box?
The answer is, I agree with you that it can be anywhere, right? Which is why initially we said, look, it's fine to put past history, review systems in the history prasinillis. But what you always need to have is the history prasinillis. Now, I'll give you just a very easy to understand example of that. And when you think about, again, using the example of chest pain, working up for ACS, PE, or dissection are very different. It's most basic EKG trope chest x-ray for ACS, a dimer or a CTA for PE, and then exclusively the CTA for dissection. How do you even know what test to order until you gather appropriate data on the patient's symptoms, right? And in this history prasinillis, there was nothing asked about dissection. There was one thing that was actually asked about PE, and they did have pain with inspiration, so pleuritic pain, which would increase our risk to some degree with PE. In some sense, they document their own malpractice. Mm-hmm. I think it's fine, just getting back to your question, actually, to put more parts of the HPI within the MDM section. As long as it's there, that's fine. And in all those legal cases that I've reviewed, as long as it's on the chart, that's not a problem. It's a little bit easier to organize it in our brain with the presentation that your resident is giving you, or maybe to look at a chart to organize it with things being in appropriate categories. But as far as medical legally or billing wise, as long as it's on the chart, that's fine. Putting in the MDM is fine also. I would not caution, but say you don't need to repeat things in the MDM. So chart redundancy is not really helpful. And if it turns out that you're spending tons of time doing that, these days, I think that's a little bit less, especially with voice activated dictation.
For sure. Now, when I have a chest pain patient of any ilk, no matter how I risk stratify them, the big three are always on my chart. And the way I work, Mike, and I'm curious to hear what your opinions are, is I have a template for chest pain. And when that template comes up, and my rule, and I think anyone should adopt this rule if you want to stay safe, is anytime I use a template, even if I just used it on the patient beforehand, anytime I use a template, I reread it in its entirety. That keeps me from doing two things. One, it keeps me from putting things in there like the patient's not on OCPs when they're a male patient. You never want to just use a template as something you press the button and that's it, you're done with the chart. That is deadly, I think. I want to alter it. I want to make it specific and customized for the patient. If they said something, if there was a quote they gave, I want that in there. It shows that it's actually really being used for that patient. But what this template does is it says for ACS, and like I have low risk chest pain, I have admitted chest pain. For low risk chest pain, it would say by heart score, patient deemed low risk, and I'll actually put the score in there. We did 2 sets of troponins, which are negative. Patient advised at low risk, but not zero risk for chest pain, must see primary care doctor to do further cardiac risk stratification. For pulmonary embolism, no tachypnea, no tachycardia. Now, obviously, if they had those things, then since I'm reading the template, they get taken out. No recent travel, prolonged inactivity and mobilization, no surgeries in the past 60 days, no leg complaints or leg finding, patient not on OCPs. And then for aortic dissection, no family history, no cocaine or speed use, no recent cardiac instrumentation, not in 3rd trimester pregnancy. That disappears for male patients. It's in bold with asterisks around it. So I know as I'm looking at it, this gets taken out. But what it's there for is to remind me. The template becomes now not just something utile for documentation efficiency, it becomes a mental cueing mechanism that makes me remember all the things I might otherwise forget. For instance, patient does not appear morphinoid. No known valve abnormalities. Pain did not start at maximal intensity. Pain not described as ripping or tearing. No radiation to the abnormal legs. No neurologic symptoms accompanying the chest pain. Denies migration of the pain. No symptoms below the diaphragm. Due to all of this, the patient's presentation is inconsistent and very low pretest probability for aortic dissection, and therefore I decided not to pursue testing. Now, to write that on each patient, Mike, would take me 30 minutes. But it's now there. It's been customized to the patient. If there was anything in it that wasn't true of that patient, it disappears. And now it's not only put it on the chart, the consideration, but it's forced me to remember things I might have forgotten. Oh, wait, this guy's 6'4" and weighs 150 pounds. Maybe I go back and reconsider my pretest probability for aortic dissection. So what do you think about this as a process, Mike?
I love it. You do something really smart, which is not simply saying, I don't think this is aortic dissection, which I see on some charts, and it turns out to be an aortic dissection. And then I'm thinking, like, how is that legally protective to say that you, in your divine wisdom, didn't think it was an aortic dissection when you didn't ask one question or the 20 questions that you just related there, or did one single thing with your exam to rule that out? Now, I'm not even talking about testing. Of course, if you have a negative CTA, dissection study is going to be pretty unlikely, of course, right? So you have actually said why you don't think it is. And this gets to a really legally protective approach to documentation, which is the more specific documentation wins. I'll give you another example, and we can jump back into this chest pain scenario and the templated approach in just half a second. But it was a patient who had a subrectal hemorrhage, and the physician documented no vomiting. The nurse documented vomiting thin liquids. The more believable documentation is the more specific documentation of the nurse. So in the same way, it's good to say with headache, just for example, the headache started gradually. That's good. That's standard of care. Everybody's cool with that. But what's better to say is that the headache started at noon and reached maximum intensity at 3 p.m. That's the more specific and more believable documentation, especially when you say pulses are 2 + equal times 4 extremities and the patient has a prosthetic leg. It makes the first thing you said more believable because you're going to have to probably defend why you said that about the second thing after. Getting back to your templated approach, this hard stop to the MDM, this self-check, this asking ourselves, does my argument make sense? If the patient bounces back tomorrow, what did I miss? This is a super, super smart way to go, and it makes your chart super defensible. Most importantly, though, it improves patient safety and decreases your risk of a misdiagnosis.
Yeah. When you talk about something like headache, where on my template, there's 12 diagnoses on there, there's no way I remember those at all. And in fact, sometimes when I put up the template, I realize, oh crap, I should go back and ask about space heaters because it's winter and I totally forgot to ask that. And so the fact that most of my clients in my coaching world, when they come to me for shift efficiency, are not using templates, it's such a waste of their time because they're documenting. Well, first of all, they're documenting the same things over and over, but usually they're documenting in an inferior fashion because no one could document this much. Now, what struck me about the case that we're talking about of this 41-year-old, Mike, is that there was no consideration of any of the big three on that chart. Let's say they wrote pulmonary embolism, and they talked about no OCPs, no recent travel, no immobilization, no risk factors, no family history. And they wrote all that. And they said, based on this, I considered pulmonary embolism, but deemed it to be below the testing threshold. Now, I still don't think that this patient's pain was pleuritic. It potentially might have bumped, depending, like this is all so arbitrary where you actually quantify your pretest probability. But the current standard is if it's less than 1.5 or 2%, you don't need to work them up. Would that have been enough? I considered PE and they gave some reasons. Do you think that would have kept us out of court? Because now instead of the doctor failed to consider, which is the real worrisome thing, and the plaintiff's attorneys salivate over, now they did consider, but they might not have considered as fully as they should have. What's your feelings on this, Mike?
With pulmonary embolism and that statement in there, I think it's extremely unlikely you're going to find an attorney to take this case. I'm not crying crocodile tears for them, but this is all of their firm's money that might be in the hundreds of thousands of dollars. And if they lose the case, they don't get anything for it. So the plaintiff attorneys, and I probably do 30% plaintiff, 70% defense, just because I review those cases doesn't mean I'm taking those cases. So for both sides, I'll say, look, you don't really have a good argument. I wouldn't pursue this further. I'm not going to be your expert because I can't either defend or condemn the care that was given, right?
Hey, folks, we're just going to stop for a second because this is a free episode. I'm giving it to you in its entirety, but it's very rare that we have these full free episodes because EMCrit is a members-only site that still has foam. But if you're enjoying this content, please consider becoming an EMCrit team member. It's inexpensive. You get CME. You could write it off on your taxes, but forget all that. What it's going to do is make you the best possible resuscitation and critical care doctor you could be. You'll have the most cutting edge, up-to-date information, and you will get it in the comfort of your car or on the subway or while running. And you'll never have to think, am I current enough or not? Am I taking the best care of my critically ill patients? All right, let's get back to the show.
But the point is that these attorneys, in my experience, don't really want to waste their time of a losing case. And if you make that argument, I think it's really unlikely. Here's another really good, and I think it's important for the listener to hear an example of an MDM that, to me anyways, feels very defensible. So consider the scenario of the 17-year-old girl who is on birth control pills, who has chest pain and is coughing some blood-tinged sputum. And you think to yourself, look, a first-year or third-year medical student would be concerned about PE because we're talking about PE, right? So maybe a medical decision-making note on that patient would be to say the patient has some blood-streaked sputum, which started after a particularly vigorous episode of coughing. There are two siblings in their room with similar symptoms of productive cough. The patient has a fever. They have no pain or swelling in their legs. They're not tachycardic or tachypneic or hypoxemic. And I feel the risk is extremely low that the patient has a pulmonary embolism. I spoke to the patient about it through the process of shared decision-making. She understands that is still a possibility, but it's extremely low. And she agrees to return if things get worse or if they don't improve or if they change. And she understands that there still remains some diagnostic uncertainty. To me, it feels like that's a really nice patient-centric note to put on there. You're not exposing her to radiation, to contrast, to expense, the time in the household, the flow through the emergency department, because look, it's very unlikely, but it's not impossible. Can I tell you about another case that is just blows my mind? This is also a case from the Bounce Back Medical Legal book. This is a similarly aged patient, a 39-year-old woman who had chest pain. And I won't give you her whole story unless you want me to go into the HPI. But the amazing part about this case is she wakes up, this is in Cleveland, Ohio. She wakes up around 5 o'clock in the morning with chest pain. She goes to the ED. They decide that it's not cardiac and they send her home. That night, after fixing dinner for her kids and her husband, she walks into the kitchen. They are startled to hear their mother and wife fall to the ground, water glass crash into the floor. They go in and find her unresponsive. The same day that she was in the ED that morning, the husband now calls 911, of course, and they say, what's the nature of the call? He says, and this is documented on the EMS form that I have, and he says she choked on a piece of chicken. And then when they arrive, EMS, and finding her unresponsive, basically in a systole, which then eventually she goes to defib and they shock her, unable to be resuscitated. Still, again, he tells them, I think she choked on a piece of chicken. This concept of the patient understanding diagnostic uncertainty when they leave the ED is so vitally important because ACEP in 2018 position statement on chest pain says there is an acceptable miss rate for ACS in chest pain patients of 1 or 2%. And then they specifically say, and I love this, that trying to get lower than that will cause harm from false positive and extraneous testing. So they've said what we talked about earlier, Scott, that failure to make a diagnosis is not malpractice. There is an acceptable miss rate, but what helps us as emergency physicians at the bedside is that the patient understands that there is that diagnostic uncertainty. They're going to return if their symptoms don't resolve or if they change or if they worsen. And that's what didn't happen with this 39-year-old woman, to the point. And astoundingly, the husband calls 911 the day that she was in the ED, thinks she choked on a piece of chicken and that she wasn't having a heart attack because they'd already been in the ED. We did the test. We ruled everything out. As it turns out, she didn't have a troponin EKG. They thought it was bronchitis. But anyways, that was the initial thought of this husband so tragically.
Now, what this case evokes in me, Mike, is a real frustration with the advice I hear from some really smart people in emergency medicine who probably are not actually doing medical legal work and therefore just don't know how horrible the advice they give is. But they will tell residents on a regular basis, if you're not going to test for something, don't mention it in the note. And, that which is antithetical to everything I believe. And then they're the same ones who don't like the idea of the patient's diagnosis and what you tell them as being a non-specific diagnosis. So for instance, if I send a patient out with chest pain and I don't know what's causing their chest pain, I just don't think it's a life threat requiring hospitalization, then the diagnosis that goes on my chart is chest pain. And what I tell the patient is, you have chest pain. I don't think it's anything life-threatening right now. It doesn't mean that can't change. And so I am still worried because I don't have an explanation. So if anything is different or it doesn't go away in a day, I want you coming back to us. Otherwise, you must follow up with your physician to fully evaluate why you have this chest pain versus bronchitis or what's worse, gastroenteritis for a patient. For me, I need to be able to stake my career on the diagnosis I'm giving. So if you get a CT scan with an appendicitis, I write appendicitis on the charts diagnosis because I'll stake my career on that. I see it on anything else. All I could stake my career on is they have abdominal pain. So if I'm sending a patient out they came in with the middle of their abdomen pain, I watched them for 4 hours, serial exams are fine, I decided not to CT them, I am not going to write gastritis on that chart. That is a diagnosis I can't swear to. What I'm going to write is abdominal pain. I'm going to tell them, right now you look okay, come back if it's worse or it doesn't go away. What is your stance on this, on writing diagnoses that aren't actual diagnoses? They're still the complaint the patient came in with.
It's really important that the patient understands that diagnostic uncertainty, which, like we just talked about, that this is chest pain. And I'll so frequently tell them that we haven't 100% excluded things, but I feel that it's safe to further continue their evaluation as an outpatient. And I'll put that in the chart also. That is a way that I can say that we haven't completed our evaluation, but that I feel that we can safely continue it as an outpatient as opposed to having to admit you to the hospital. And then speaking to what you mentioned just initially, as far as diagnoses and testing, I remember many years ago at the Ohio State University, when I was a medical student, I remember one of my attendings said, if you think of PE, you should test for it. And even at the time, being a lowly renegade medical student, I always thought that was just a little bit off because we should always think about PE when we're walking in the room. But when I see the patient has been hit in the chest by a baseball and they have reproducible left lower sternal border pain, which causes facial wincing and then to withdraw and yell, ouch, at that point, I don't think it's going on anymore. So our history and our physical exam are testing. They are data gathering in the same way that some sort of objective test like a CT scan or a CTA or for appendicitis, CT, abdomen, pelvis, whatever that would be, without a doubt, this differential. And I wanted to, if it's okay with you, Scott, speak to another thing that a lot of people do, and I see on charts, the 20-item differential diagnosis. Mm-hmm. And I'm sure you've seen it also. If we are doing something for someone else, the billers and coders, I think that's fine, but realize what they need. Don't ask them to hold the hoop that we're forced to jump through to hold it higher. So you can't bill more for a 20-item differential than for a 10, than for a 5, or even for a 2 or 3 item differential. So mentioning something on your differential, gathering zero data with that, with history of physical or testing, right? And history of physical is the way that we gather most of our data, of course, right? And gathering zero data, and then it turns out to be that diagnosis, there's no way that can help us. What do we expect? Partial credit? Oh, I considered this bad diagnosis. I didn't do anything to look for it, and then it turned out to be, but at least I considered it. Can I have some partial credit? In some ways, to me, it feels like that would be even worse. A computer-generated differential or some super long differential after we've evaluated the patient of stuff that couldn't be possibly going on, unless you can address that in your medical decision-making note, to me, it feels like medically legally, that's worse than not mentioning some rare thing that you know for sure is not going on, and you're just hoping that the 1 in a million doesn't occur.
Yeah, that's baffling. I've never seen that. But if I just saw a 20-item differential with no consideration for why they were able to think about that and then rule it out, that just seems, yeah, I agree with you. That seems worse than not doing that in the first place. What I think is needed, and we've demonstrated this with chest pain, but I think for every diagnosis, if you haven't already done this in your career, this is the time while you're listening to this episode is afterwards sit down and say, okay, for each of these possible presentations, what is the thing that I'm going to miss that's going to be a problem? And we spoke about headache, right? So there's so many on headache that you need to consider, right? Now, the obvious one we all consider subarachnoid hemorrhage, great. But there's so many others that are potentially low frequency, and yet you're totally going to miss if you don't have them. So for me, having a headache one, having 12 items on the differential is not uncommon, but each of them actually has a set of reasons why I don't think that is the case. Like, how often on your chart for headache or in your actual evaluation of the patient are you actually remembering spontaneous intracranial hypotension or any of the others? If an older patient comes in, temporal arteritis, all of these are ones that are so easily forgotten, but I do think need to be there and potentially will actually need to be worked up. If a 70-year-old comes in with a headache and you didn't at least consider temporal arteritis, you're in big trouble, right? That's something that is absolutely crucial. And so I think people, because they are having false notions of what is protective and what isn't, wind up doing a whole bunch of extra tests thinking that's going to protect them when what they actually needed is to just spend a moment thinking through what the diagnosis could lead to. Mike, what's your thoughts on this?
That's exactly right. And when you think of headache, it's a perfect example. There are so many potentially bad things that you don't find on testing. And I have this exercise that I take the residents through. It's like the patient has a negative CT, a negative LP, and then they come in the next day with the headache. What do we miss? And it turns out, and I have the list of 8, but there's many more than that, right? Of things that could still be going on with a negative CT and LP, and things that you can either diagnose or strongly suspect at the bedside just based on your history and physical alone with no testing whatsoever, like papillodemus for tumor cerebri, or like you said, giant cell arteritis, or acute ankylosing glaucoma, carotid dissection, a cerebral venous thrombosis, postpartum preeclampsia. There's so many things that could still be going on that you can suspect just with your history of physical alone. And so that's another big medical legal risk, which is exactly what we started this with as far as failure to diagnose, is that consideration of some life-threatening problems.
Absolutely. Mike, what other pitfalls have you identified throughout your work in both bounce backs and as a medical legal expert that really EM docs are doing and probably shouldn't be?
One thing is with the physical exam, and I see so frequently, alert and oriented times 3. That's good, but I'll tell you what's better in the 2-year-old who you probably didn't ask about person, place, or time to say something like, this patient is running down the hall screaming and laughing while their parent is chasing behind. I'm not saying for sure they don't have appendicitis or bacterial meningitis, just saying probably that's not what's going on. In the same way, I'm happy to send home a 50-year-old with a history of cardiac disease who comes in with chest pain if they have reproducible chest wall pain, but not just to say reproducible chest wall pain. Maybe when I press in that left lower sternal border, they have what we talked about before, the facial wincing, and they yell ouch with pain. Yes, that's the exact pain that's causing my chest pain when I come in. Again, that's with our negative testing that we do in the ED, right? It's an argument that you're making. That's your does the gloves fit moment to say in there. And maybe another example, and I really love this example, it's good to say the medial border of the right lower leg has a 4x6 area of erythema and warmth. That's good. That's fine. That's standard of care. But what's better is to say on physical exam, there's no crepitus or necrosis or fluctuance or bulla or ecchymosis. Because what you're saying before you even get to your MDM is that you think it's cellulitis, and then more importantly, and you don't think it's a necrotizing soft tissue infection or some other process.
That just really encompassed exactly what needs to get across, which is, and when you actually delve into the cognitive psychological literature on how emergency medicine works, we are doing hypothetico-deductive reasoning, meaning that we're not just a data gathering machine. We're not a first-year medical student who just is going to spew out 50 pages on an HPI and then an entire medical student level physical. And then at the end of it all, we could just go through the 40 items on a differential that you mentioned. That's not how we work. We'd see one patient a shift. The way we work is as we are seeing the initial pieces of a history, the initial parts of a physical exam, we're already zoning in on potential diagnoses and then ruling them in or ruling them out or pushing their probabilities higher or lower in the course of the actual history and physical. You're zoning in questions. You're figuring out, this is what I need to examine. And we do this automatically, but so little of it goes in the chart. And that same method of you documented, just as you say, okay, here's the area of warmth and possible cellulitis. But what you should also be saying is, how I'm going to show anyone looking at this chart that I considered the life threat, necrotizing fasciitis. And here's the reasons why I didn't get a surgical consult and a CT scan. And if that's not there, if that piece is not there, then even if you did that correctly in your mindset and what you actually did, if that's not on the chart, you're hosed. And if the patient turns out not to have necrotizing fasciitis, you're fine. And that's 99.9% of your patients. But in the 0.1% that did have it and you missed it, if those items were there, anyone looking at a chart would say they tried. They did this was the rare case that presented with a completely benign exam and then got much worse a day later, which does happen, versus no matter what you actually did, what any plaintiff's attorney, what any quality assurance committee of the hospital is going to say is this doc was slipshod, didn't consider necrotizing fasciitis, and therefore what you don't consider, you cannot see. And that's what they're going to think.
So what you're talking about is really something that Pat Crosscarry talks about with this playing the odds bias. You're just hoping to get lucky. And as it turns out, only 1 in 10 or 1 in 20 chest pain patients will have a ACS or life-threatening type of process. You can send every chest pain patient home without even seeing them, and you're going to be usually right. But the fact is, we're going to see between 150 and 175,000 patients in our career. And based on data by SCLAR and a new study that we're actually starting and actually have already started looking at this tachycardia and tachypneic question again, and bounce backs and death within 7 days, they found about 1 in 10,000 patients had come back with a possible error and died within 7 days. During the course of your career, if you have 10 or 15 of these patients, that's still a lot. You can get lucky because most patients don't have neck fash, but we're not thinking with our careers of that quantity of patients that we want to get lucky. Hopefully, with the experience that you and I have and folks starting earlier in their careers, we're going to think, what is the thing that could, and getting back to, again, what we said in the beginning, kill that person? What is the thing that could be that question that we never want to be asked? Remember that patient that you saw last night, right? And why not think about that before the patient leaves the ED and put something on the chart as to why you don't think that thing is going on? Really wrapping all of this together, our chart needs to tell a story, and it needs to be a cogent argument for why what we did was reasonable and what we didn't do was not necessary to be done in the first place.
I love it. Mike, maybe we finish up with what other complaints or presentations do you find particularly high risk?
So the big things now, medical legally, stroke is a really big one. Spinal epidural abscess is a really big one also. And if you have patients that are high risk for those things, just put in your chart why you don't think those things are occurring. Now, again, we don't always have to be right, and we don't want to do CTs and CTAs on 10,000 people to catch one stroke. That's not going to be overall helping the healthcare system, helping everybody. But on the other hand, when we don't think a stroke is occurring, in the same way, when a stroke is occurring, we say, thrombolytic therapy was not indicated because intracranial hemorrhage or whatever reason, In the same way, say why you don't think that stroke is occurring, why that spinal epidural abscess is not occurring, why that ACS PE dissection is not occurring. It self-checks us in the same way that your templated notes self-check us. It's that hard stop in the MDM to say, if there was a bad outcome, would I feel comfortable defending my care to the patient's family, to my ED chair, to a jury, right? And if you wouldn't feel comfortable before the patient leaves the ED, go back and get additional information. Now, that doesn't necessarily mean testing, but it might just be extra history and physical information. Make sure that your chart does tell a story and that you've not documented your own malpractice. And in the end, probably the biggest phrase, and I've used this in the past, and many lectures with this phrase, is that I don't want people to practice defensive medicine, but to evaluate and document in the way that is defensible.
That is the perfect place for us to stop, Mike. I cannot thank you enough. I'm sure that we'll have to have you on again. I'm sure this is going to raise many questions. But before you ask Mike those questions, buy the damn book and read that, because it will give you an education that is sorely lacking in every residency training program that I have seen. We are not taught to properly document, and we're not taught to properly keep our careers defendable so that you don't need to wind up in court. And the chances are we'll all be there. But if you're there with a wonderful chart, you're going to feel so much more potent and have so many more options than without. Mike, thank you again.
It's been an honor, Scott. Thanks so much.
So I want to just reiterate and emphasize some of the amazing points that have been made and add some new ones. The first thing to mention is that at the end of your documentation, however you do it, whether it's templates, whether it's dictation, whether it's a scribe, what have you, there should be a moment where you do 2 timeouts. The first one is a billing timeout, if you're in the United States, where this really matters. I mean, this could be the difference between you looking good in your group and you falling behind, because you really want to get all of the available billing that's appropriate for the patient services you've just rendered. So you do a billing timeout, you look at your chart, you ask yourself, have I hit all the points I need to bill? And there are a lot of them are counterintuitive. Just good documentation oftentimes doesn't bill very well. You need good documentation plus billing awareness. That's a lot of what our course dealt with. But then the second one pertinent to this episode is you need a safety timeout. And during that safety timeout, you ask yourself some questions. This just takes a few seconds if you've done your documentation right. And if you've done it wrong, it's going to take longer, but that's good because it's going to save your ass. So you ask yourself, what could I be missing? And, the other substitutes for that question that are more powerful for me are, how am I going to get sued from this case? What's going to lead me to get a call tomorrow morning from the CMO? What is going to get me into a morbidity and mortality conference? So I ask myself, what am I missing? How am I going to get screwed on this patient situation that I haven't addressed? All right. The second one that Mike keeps bringing up, did I answer the question the patient's presentation was asking? If someone looks at this chart and looks at their presentation, it starts asking questions in their mind that your MDM better answer. If the patient presents with chest pain and it has a pleuritic component and the patient's a little bit tachycardic, the question anyone looking at the chart is going to be asking in their head is, did they address pulmonary embolism? And then your MDM should answer that question. And if it doesn't, then your MDM is insufficient and, it's a potential liability. All right. Have I documented the workup for why or why not I didn't take every single possible serious life threat and either test for it, or in the case when I didn't test for it, the reasons why? That is what you need to consider for every patient. Every patient needs a think through of what life threats are associated with these complaints, and did I either test for or give the reasons why I didn't test for each and every one of them. And if any of your attendings, if you're in training, is telling you, oh no, if you don't test for it, don't write it, they do not know what they're talking about. They do not know what you're talking about. Every single life threat or serious condition needs to be addressed in your MDM for either why you didn't test for it or the test that led you to say you're done with it. If you don't have those, you're screwed. Now, the point they might try to be making to give them the benefit of the doubt is, if you're just going to write, I considered pulmonary embolism with no explanation for why you didn't test for it, that's not going to serve you well. That might actually be deleterious. We mentioned that. So mention them and then all the reasons why you didn't test for them, if indeed you didn't test. All right, next up, make your patient aware of your diagnostic uncertainty, if you have any, and have the chart reflect that you made them aware of this, right? So don't send them home with chest pain that you feel it's low risk, you're not going to do any testing, and make them feel like, oh, it's no big deal. Don't you worry about it. We didn't find anything, it looks fine. Those patients will not come back if it gets slightly worse. What you want to do is you want to put the fear of the condition into them, and look, yes, your patients are not going to sleep as well at night until they actually get the follow-up for definitive testing, but that's what we want. We want them to go home saying, that doc was really nice, but he didn't give me an answer here. I don't have an answer for why I have chest pain. I want an answer. I'm going to go see a cardiologist. I'm going to go see my PMD. That's what I want my patients doing. I don't want them saying, oh, I'm so reassured by Dr. Weingart. He said that chest pain, he doesn't see anything serious right now, so I don't have to worry about it, even if it gets worse or changes or doesn't go away. No, I want them saying, wow, they were super sweet in that ED, but they didn't give me any answers. No answers were given. Better go find someone smarter who could give me answers. That's what you want your patients doing. Please leave the diagnostic uncertainty there. And by that same light, never, ever give the patient or put on the chart a diagnosis you would not bet your house on, because you might be betting your house on that diagnosis. So if you've gotten a CT evidence of something, then by all means, give them the named medical diagnosis. But if you don't have an answer that you're willing to bet your house on, don't give them the answer. Stick with the chief complaint. They come in with chest pain. You don't know what's causing it. Doesn't seem like it's anything serious right now. They go out with a diagnosis of chest pain. That is their diagnosis. Any attending who tells you differently does not know what they are talking about. And if you were trained that way, stop doing it. Do not put wastebasket diagnoses that you would not bet your house on. For instance, costochondritis. I don't care if there's reproducible chest pain to some exact point on the chest. In your mind, you could say, this is surely costochondritis. But you don't tell the patient that, and you don't put it on the chart because there's no benefit to that. You tell them, I don't think it's serious. Here, take some NSAIDs, but follow up with your doctor because we don't have a definitive answer because you can't definitively diagnose costochondritis. Same thing with gastroenteritis. I don't care if they're puking and they're having diarrhea. They go home with a diagnosis of abdominal pain and diarrhea or vomiting and diarrhea because I cannot bet my house on gastroenteritis. Now, I tell them all the stuff, like I think this is going to go away. It's most likely related to a viral infection, but I am not absolutely sure. So if it gets worse or it doesn't get better, then you come right back to us or you go to your doctor. You leave them with the diagnostic uncertainty unless you're certain. All right, and the last point, the point Mike kept making, the more specificity, the better. So it's not just A&O times 3. It's A&O times 3, and the patient was smiling and told me stories about her grandchildren. Anything that makes the people looking at the chart know you actually saw the patient, you interacted with them, and that they were looking good, if they were looking good. And by the same token, if a patient looks bad, then be specific about how bad they look, because that's going to sell the admission and the potential, to sell higher levels of care or the potential to sell a critical care note. So be specific. Show you actually interacted with this patient and give some juicy details to elaborate on that interaction. All right. I think that's where I'll stop. This was a long one. This has been Scott Weingart for the EMCrit podcast saying bye-bye.